Section 1. A Doctor's Introduction to Celiac Disease. Section 1. A Doctor's Introduction to Celiac Disease. As a physician and researcher, my goal is to bring clarity to celiac disease. I want to provide simple, trustworthy information that empowers you. Think of this as a conversation, a starting point to understand what's happening inside your body. We will walk through this together, breaking complex science into plain language. My aim is not to overwhelm you with jargon, it's to equip you with knowledge and confidence. So, what exactly is celiac disease? It is a serious autoimmune disorder. It occurs in genetically predisposed people. Ingestion of gluten leads to damage in the small intestine. Gluten is a protein found in wheat. Gluten is a protein found in barley. Gluten is a protein found in rye. When someone with celiac consumes gluten, their immune system attacks the small intestine lining. This is not a simple food allergy or intolerance. It is a complex immune reaction affecting the whole body. Understanding this distinction is the first step to proper management. The small intestine is lined with tiny finger-like projections called villi. Picture them like the soft bristles of a carpet. In celiac disease, the immune attack flattens these villi. Damaged villi can't absorb vital nutrients like iron. Damaged villi can't absorb vital nutrients like calcium. Damaged villi can absorb vital nutrients like vitamins. This malabsorption causes many symptoms, from digestive distress to long-term complications. It's crucial to understand why this matters. Celiac is not a dietary trend or lifestyle choice. It is a medical condition requiring a specific lifelong treatment. If left undiagnosed or untreated, it can cause a cascade of serious health problems. These can include chronic anemia. These can include osteoporosis. These can include brittle bones. These can include infertility. These can include neurological conditions. These can include an increased risk of certain types of cancer. The good news, with correct diagnosis and a strict lifelong glow-out limpi in si get linti gatis for the small intestine can heal. Section 3. Decoding the body's signals, common signs and symptoms. One of the greatest challenges in diagnosing celiac disease is its chameleon-like nature. It can present with a vast array of symptoms that vary dramatically from person to person. The classic symptoms that many people associate with the condition are digestive in nature. These often include chronic diarrhea, watery, diarrhea, fatty, pale stools. Many individuals experience significant abdominal pain, cramping, a feeling of being uncomfortably full or bloated, particularly after eating. Conversely, some people, especially children, may experience chronic constipation instead of diarrhea, further complicating the diagnostic picture and delaying recognition of the true underlying problem. However, it is a critical misunderstanding to think that celiac disease always involves the gut. In fact, a growing number of patients are diagnosed with non-gastrointestinal or atypical symptoms. Unexplained weight loss despite a normal or increased appetite. Pervasive, debilitating fatigue not relieved by rest, linked to the body's inability to get the energy and nutrients it needs from food. Anemia resulting from poor iron absorption is frequently the first and only sign found on routine blood tests. The skin can also provide important clues. A specific type of intensely itchy, blistering skin rash known as dermatitis herpetiformis. This rash typically appears symmetrically on the elbows, knees, buttocks, and back. For individuals with dermatitis herpetiformis, the gluten-triggered immune reaction manifests in the skin rather than the gut, and many of these patients have minimal or no digestive symptoms. Inside the mouth, recurring canker sores, aphthous ulcers, defects in tooth enamel, and an unusually red, smooth tongue can also be signs of the underlying malabsorption and inflammation caused by the disease. In children and adolescents, the signs can be particularly subtle and easily misattributed to other causes. Poor growth, a failure to gain weight, falling off their growth curve, delayed puberty is another critical warning sign. Beyond physical growth, behavioral and mood changes, such as increased irritability, anxiety, or difficulty concentrating in school, recognizing that these diverse symptoms, from a skin rash to mood swings, can all point back to the same root causes essential for ensuring that no one slips through the diagnostic cracks. It's about protecting your overall long-term health. Section 4. The doctor's perspective. Clinical features and examination. When a patient comes to me with symptoms that could suggest celiac disease, my evaluation begins long before any tests are ordered. My evaluation really begins with conversation. The first step is a thorough conversation to gather a detailed medical history. I will ask about the specific nature of your symptoms. I will ask about the duration of your symptoms. I will ask about the frequency of your symptoms. For example, is the diarrhea constant or intermittent? Does the bloating happen after every meal or only certain ones? I will also inquire about your family's health history. Parent, sibling, child. Having a first-degree relative raises your risk up from about 1 in 100 to as high as 1 in 10. Next, I perform a comprehensive physical examination looking for subtle clues. I will carefully check a patient's height. I will carefully check a patient's weight. I plot them on a growth chart, especially for children and adolescents. I will press gently on the abdomen to check for tenderness, distension, or bloating. I will listen to the abdomen with a stethoscope for bowel activity. The examination extends beyond the abdomen. I will look for signs of nutritional deficiencies. I will check the skin for pallor, which could indicate anemia. I will check for rashes, especially the typical locations of dermatitis herpetiformis. I will examine the inside of the mouth for canker sores. I will look for dental enamel defects. I will check for swelling in the ankles, edema from protein loss. I will assess reflexes and sensation in the hands and feet. Finally, I synthesize the patient's story, the family history, and the physical findings to form a preliminary assessment. If the collection of signs and symptoms points strongly towards celiac disease, I will explain my reasoning and discuss the next steps, which involve specific diagnostic testing. For example, if a child presents with poor growth and a family history, the suspicion is high. If an adult presents with unexplained iron deficiency, anemia, and bloating, celiac disease is a primary consideration. This methodical approach ensures testing is targeted and meaningful, moving us closer to a definitive answer. Section 5. Unmasking the culprit, the diagnostic journey. The first step in laboratory testing for celiac disease is a simple set of blood tests. These tests are not looking for gluten itself, but for specific antibodies that the immune system produces in response to gluten. The most sensitive and commonly used test is the tissue transglutaminase IgA antibody test, often abbreviated TTG-IgA. Tissue transglutaminase is an enzyme in the intestine targeted by the immune system in celiac disease. High levels of these antibodies are a strong indicator of the disorder. At the same time, we also test the total level of IgA antibodies in the blood to ensure the person is not IgA deficient, which can cause a false negative on TTG-IgA if the TTG-IgA test comes back positive, or if suspicion remains high despite a negative test, especially in cases of IgA deficiency. Other antibody tests may be used. Endomysial antibody EMA test, deamidated gliadin peptide DGP IgG test, useful for children under 2 and EGA deficient individuals. It is absolutely critical that you do not stop eating gluten before these blood tests are performed. If you remove gluten from your diet, your body will stop producing these antibodies and the tests may return to normal, making an accurate diagnosis impossible. If the blood test strongly suggests celiac disease, the gold standard for confirming the diagnosis is an upper endoscopy with a small intestine biopsy. While this may sound intimidating, it is a routine and safe procedure. A gastroenterologist will guide a thin, flexible tube with a tiny camera on the end, an endoscope through your mouth, down your esophagus, and into the first part of your small intestine. The camera allows the doctor to see the intestinal lining directly and look for visible signs of damage, such as scalloped folds or a flattened appearance. The procedure is typically done with sedation to ensure you are comfortable and relaxed. During the endoscopy, the doctor will use tiny forceps passed through the endoscope to take several small tissue samples, biopsies from the intestinal lining. These samples are then sent to a pathologist who examines them under a microscope. The pathologist looks for the characteristic damage of celiac disease, villus atrophy, the flattening of the villi, and an increase in inflammatory cells within the tissue. The confirmation of this damage on a biopsy, combined with positive antibody tests, provides a definitive diagnosis. In some specific pediatric cases, guidelines may allow for a diagnosis without a biopsy, but for most adults it remains an essential step. Section 6. The path to healing, treatment and lifelong management. It is important to understand that there is currently no pill or medication that can cure celiac disease or prevent the immune reaction to gluten. The cornerstone of treatment and the only effective therapy is a strict and lifelong adherence to a 100% gluten-free diet. This is not a temporary measure. It is a permanent lifestyle change. By completely removing gluten from your diet, you stop the autoimmune attack on your small intestine. This allows the intestinal villi to gradually heal and regenerate, restoring their ability to absorb nutrients properly. Your doctor will likely order a baseline set of blood tests to check for any nutritional deficiencies. Common deficiencies include iron, vitamin B12, folate, vitamin D, calcium. Based on these results, your doctor will recommend specific supplements to help replenish your body's stores and correct issues like anemia or low bone density. It is also essential to schedule a consultation with a registered dietitian who has expertise in celiac disease. A dietitian can teach you how to read food labels, identify hidden sources of gluten, build a balanced, nutritious, and enjoyable gluten-free diet. Medical follow-up is a critical component of long-term management. Typically within 1 year of diagnosis, your doctor will repeat the celiac antibody blood tests like the TTG-IgA. As your intestine heals and you are no longer exposed to gluten, these antibody levels should decrease and eventually return to the normal range. Healing is a gradual process that varies for everyone, from several months in children to 2 years or more in adults. If symptoms do not improve despite your best efforts on the diet, your doctor will investigate other possibilities. This could include accidental gluten cross-contact, the presence of another coexisting condition like lactose intolerance, or, in very rare cases, a form of refractory celiac disease that requires additional medical intervention. Section 7. Living gluten-free. A practical guide to diet and daily life. Adopting a gluten-free diet means learning a new way to look at food. At its core, the rule is simple. Avoid all foods containing wheat, barley, rye. Naturally, gluten-free foods will become the foundation of your diet. Plain fruits and vegetables, fresh unprocessed meat, poultry, fish, eggs, milk, cheese, yogurt, legumes, beans, nuts, seeds, rice, corn, potatoes, quinoa, buckwheat, millet. Many manufacturers also produce certified gluten-free oats which are safe for most people with celiac disease but should be introduced carefully. The biggest challenge comes from processed foods where gluten can be a hidden ingredient. You must become a diligent label reader. Malt, brewers, yeast, semolina, durum. Look for products that are explicitly certified gluten-free. When in doubt, avoid it. Beyond choosing the right foods, you must also be vigilant about preventing cross-contact. Cross-contact happens when a gluten-free food comes into contact with gluten, making it unsafe to eat. This can happen easily in a shared kitchen. To prevent this, use a separate toaster or toaster bags for gluten-free bread. Use separate cutting boards, colanders, and utensils for gluten-free food preparation, or wash them thoroughly with soap and water before use. Store gluten-free items on the upper shelves of your pantry and refrigerator to prevent crumbs from falling onto them. Simple habits like washing your hands before handling gluten-free food can make a big difference. Living with celiac disease extends beyond your own kitchen. Eating out requires planning and clear communication. Call restaurants ahead of time to ask if they can safely accommodate a gluten-free diet. When ordering, speak directly to the manager or chef about your needs. Explain that you have celiac disease and require strict precautions to avoid cross-contact, not just the removal of gluten ingredients. Joining a local or online celiac support group can be incredibly helpful. Sharing experiences, recipes, and restaurant recommendations with others who understand your journey can provide immense practical and emotional support, making your transition to a healthy, gluten-free life much smoother. These risks can be significantly reduced, allowing people to lead full, healthy lives. I'm Dr. Asad Saleem. If this helped you understand celiac disease, signs, symptoms, clinical features, diagnostic tests, treatment, diet, and precautions, please like, comment, and share. For more, follow the channel Asad Saleem from Sersom Semfor and make sure to subscribe. Together we can turn clarity into action and better health.